Banu Atalar is a professor of radiation oncology at Acibadem MMA University, Istanbul, specialized in SRS and MR-guided adaptive SRS, stand for trained. She focused on CNS, thoracic, and GI with the 70+ publication and has received major international honors. So please welcome.
Thank you so much. Good afternoon, everyone. I'd like to keep you as short as I can. So since we have learned a lot about liver SBRT and motion management, I will briefly talk about MR-Linacs only in gastrointestinal cancers. So about the role of radiotherapy in gastrointestinal cancers, you know, the ones you're interested in, GIs, know that the role of postoperative radiotherapy is diminishing. There's no role for gastric cancer or postoperative pancreatic cancer, or even we are discussing many more about rectal cancers as well. But unfortunately, even preoperative radiotherapy is decreasing for esophageal and rectal tumors as well. But in oligometastatic disease, SRS has taken its leading role in every cancer, and liver mets SRS has an increasing trend, but it's still in comparison with the RFA and microwave and prospective data is lacking. And SRS for inoperable tumor is increasing, and there's a new era for the dose escalation in non-operative management of rectal cancer. So in this talk, I'm not going to talk about the indications of all GI cancers and about how we treat them. I'm just going to talk about how we can use MR-Linacs in treating gastrointestinal cancers. So we all use different types of advanced radiotherapy machines. The conventional radiotherapy machines, they all use KV, and cone-beam CT for IGRT. Mostly all of them need marker depending on the team's experience, of course. The new generation machines has online adaptive systems, but none of them has real-time 3D tracking during treatment. The difference of our MR-Linac system is it's coming with the MR-based SGRT, and you can even use functional MRI during treatment, cine-MR tracking, real-time tracking, and the most advantageous thing is the adaptive online treatment, which makes MR-Linac different than the other systems. So the image guidance is the most important issue during SBRT. We all need better quality images to see what we are treating and what we don't want to treat, right? And in the abdomen, CT guidance is always tricky because we have gas and the bowels are always limiting our vision. There are sometimes artifacts because of some surgical clips, but simply just because of that gas, there's a lot of movement, and this movement really scares us while we are doing our treatment. So image guidance, when you use MR in the abdomen, does help you to do dose escalation, to have lower side effects, and possibly we can increase local control and overall survival with that. When we look at the, I'm not sure if you can see it, but the workflow is a little bit different than our normal workflow. I mean, so the initial assessment, immobilization, and simulation, and contouring and planning part is the same. But when we go on the treatment, we have to do the setup, the MR monitoring, the registration, we have to do recontouring, and then we have to do, if you want to do adaptive radiotherapy, we have to do re-optimization, and we will have some position verification, and then we can go to the treatment. So this means that it takes a lot of time. So in my experience, it's not necessary to use it in your conventional fractionation because it takes a lot of time, it needs experience, it needs stuff to do it. You need a doctor, you need a medical physicist, you need a very good dosimetrist in the room. So that's why I've been using our MR Linux for SRS only for limited fractionation. And what we have in our MR Linux, I have used Meridian for a long time, since 2018, and then since it's broken, we have been using a Unity machine, Unity MR Linux, and we have been using audio-visual coaching. So deep inspiration breath hold is still very helpful to decrease motion. So we use our homemade prismatic glasses for audio-visual coaching, and patients can hear and also see our screen on the back of their table, and they can participate their treatment by controlling their own breath. They even like this so much. If you guide them before treatment with the team, if you show them how the system works and what they must do, and they are really very good at it. So when you do adaptive radiotherapy on day. So let me show you what we have on our dose volume histogram. So the dashed lines shows our original plan, which was done after simulation CT. Every dose is just like what we wanted to achieve, right? So when we are treating the patient with an MR Linac, we have to merge this original plan with today's or each day's anatomy. And then we get the solid line dose volume histogram, which is not nice. This was not we want to see, right? So you have to adjust it according to your today's or each day's anatomy, so that you can get the normal dose that you want to give to the patient, and you can protect your normal tissue as well. And you can see it also in these nice graphs. You can easily notice the yellow boxes that your doses are not fitting. So you have to do an adaptive plan every day. And when you do adaptive plan re-optimization, you can get the doses that you wanted to, and you proceed with the treatment with the new dose volume histogram you have. So so here comes the question: can we increase the total dose by using better technology? I guess we can. It's, at least up to my experience, it is. So we have better soft tissue contrast and visualization of the targets and critical structures, and we don't need invasive markers. I don't like to use invasive markers, especially for treating liver mets, because whenever I send my patient to an invasive radiologist to put a fiducial in the patient, that they say, why don't I treat them with RFA or microwave? If I can put a fiducial, I can do that. So we don't need anybody for while we're treating with MR Linac. We can use smaller PDV margins because we can watch what's happening during the treatment. So we have lower normal tissue radiation exposure. And as I mentioned, online daily adaptive radiotherapy is a major advantage. And since we have the real-time cine-MR during tracking the tumor, so it's safe. You can see whatever happens to the patient while he's or she's inside the machine. So basically, any GI tumor indication that you would normally treat with a conventional with a conventional Linac can also be treated on MR Linac, because the dosimetry is the same. However, if you really want to take the advantage of an MR Linac guided radiotherapy, we can say, namely adaptive radiotherapy and real-time tumor tracking, I think it's better to use SBRT for this type of tumor. So these are the areas that I have experienced: liver metastasis, mostly hepatocellular carcinomas. I have, like, not much, but many patients with cholangiocarcinoma and many treated with pancreatic carcinoma. I haven't treated rectal carcinomas with MR Linacs, but there is a new era that I will mention later about rectal cancer. So for the liver mets, I will not go too far about the literature, but it's the significant data began to come in 2018 is about liver mets. So the German Society has reported their outcomes of over 600 oligomets, and they had pretty good local control rates where they showed that the systemic therapy before SABR, PTV volume and bed isocenter, advanced motion management, and SBRT treatment before 2003 as independent significant variables. And their results suggest that if BED isocenter of more than 150 gray was applied, local control is more than 80% at 2 years can be achieved. But the most interesting and relevant finding of this study about this topic is the patients treated with advanced motion management and after 2003 had a better significant local control when you compare it to the previous era. So this is certainly because of the increased use of advanced techniques, which means with better technology, we move a step forward for better local control and survival. And this is the famous RSS registry trial, included more than 400 patients from 25 centers, mostly colorectal mets. All of them were treated with CyberKnife, and I want to take your attention to the median lesion volume, which is 40 cc, which is quite large, and the minimum dose was 45 gray given in 3 fractions, median dose was. And they demonstrated that both small tumors and higher BED had a better local control and overall survival. So SABR works better for tumors less than 40 cc, but better BED 10. It would be better if you have a BED 10 or more than 100 gray. So smaller volume and higher BED are better. But what they did is to look deeper in the relationship between volume and the dose. As you can see, if you have a small tumor less than 40 cc, then the significance of high BED is lost. But for larger lesions over 40 cc, we definitely need higher doses for better outcomes. So we should keep in mind, if you see a larger tumor, we have to give a higher dose. So here's our data, which we have treated in my hospital. We have reported first 24 patients and then later updated to 65 lesions of liver mets treated with MR-Linac between 2018 and 22, and our median dose was 45 gray in 5 fractions. And we have obtained even better local control and overall survival with modern technology, with no grade 3 or more toxicity with this group of patients. So I would just like to share one of my patients, which I have treated. She was one of the first liver mets that I've treated on MR-Linac. She was a young colleague. She's a thoracic surgeon diagnosed with lung cancer, and she had an operation after neoadjuvant treatment, and 3 months later developed a liver met, unfortunately, and she had metastasectomy. And right after, like a year left after, she had another liver met in the liver. And you can easily see the liver met on PET-CT and the diffusion MRI, but you cannot see the lesion on a contrast-enhanced MRI. And so, firstly, the surgeons, so the patient, so she's a surgeon as well, but they said it's not operable, we cannot operate it. And it was also same for the interventional radiology; they didn't do anything. So I was so proud to treat the patient, but it was not seen in a normal contrast enhanced MRI, but luckily it was seen in our TrueFist images on the MR-Linac, which you cannot see it on a regular MR, right? It was so interesting, but we can easily see it. And we treated her with 60 gray in 8 fractions because I was scared. It was my first patient, and she was a surgeon, but she was treated very well. So as you can see, if you just tell the patient to keep the red circle within the yellow circle briefly before treatment, they really do it very well. And she did a good job, really. And so 3 months, I basically watch every patient follow up at 3 months with a PET CT after SBRT, and there was nothing. And she's still tumor free, and I see her every year. Yeah, she's doing fine. So for hepatocellular carcinomas, I will not go into detail. I'm not sure about timing. Did I finish my time? 5. Okay, great. So I will not go into the details, but we have pretty good guidelines about hepatocellular carcinoma SBRT. If you're starting this very new, you can just look at it. There are the recommended doses and safe dose constraints. But what I want to underline is the strongest recommendation is that if you are using SBRT or moderate hyperfractionation, you should use respiratory motion management and daily image guidance. So this is very important. Whatever machine we are using, we have to be careful about the technique. So this is one of the hepatocellular carcinoma patients that I have treated, which was a huge liver met, but she had no toxicity after treatment. She's still under my follow-up. I treated her with 5 times 8 gray. And when you compare the data with the RFA and SBRT for hepatocellular carcinoma or the liver mets, it's always the size always matters. So SBRT does better for the tumors which are larger than 2 centimeters. So for pancreatic cancers, we have a lot of data, prospective data about pancreatic cancers, but I believe it's the most tricky one to treat a pancreatic cancer because it's surrounded by all of the bowels, gastric stomach, and it's really risky, and we're not really very used to the MR anatomy as well. But there's pretty good literature out there from Miami group, which they have published all about their toxicities and survival rates. They have treated unresectable patients mostly, and they have shown very low grade 3 toxicities and pretty good overall survival. And there are also data which they have treated after neoadjuvant chemotherapy. As you can see, even with this advanced group of patients, they had only 5% of grade 3 acute and late toxicity. So in my department, we have treated like 37 patients. Most of them were treated with 40 or 45 grade, depending on the organs at risk in 5 fractions. And we didn't have much acute or late toxicity, but we did have a grade 5 late toxicity or gastrointestinal bleeding for one patient who had a duodenal invasion after regression of the tumor. So I don't know if it's because of the tumor or if it did it. And we had really very good results after radiation therapy, which is comparable with the literature as well. And for rectal cancer, as we all know, non-operative management is rising a star for distal rectal tumors, and our friends in Tübingen are running a trial on dose escalating for non-operative management candidates with Emorlinac. So what they do is to do adaptive Emorlinac boost once in every week, and their results will be published at ASTRO this year, I believe. So with better tumor imaging, with better IGRT, with real-time tumor tracking and online adaptive radiotherapy, I believe we can give higher doses. And what I experience is there's less toxicity. So I think Emorlinac is the future for gastrointestinal SBRT. So with that, I would like to finish my talk, but I also would like to invite you to our first international radiation oncology meeting, which will be held in Istanbul in June. I would like to invite all of you to our symposium in June, and I'll be happy to have your abstracts if you submit to our meeting. Thank you so much.
Thanks, Prof Banu Atalar. Do we have any questions from the audience? We'll go to the next, I think we'll have to skip the question part.